CPD points for the meeting. At the end of the talk, please post your HPCSA number in the chat and Google will extract and send on to the Wits Health Consortium. So I'm also going to mute my microphone. Graeme, once you start talking, we'll start recording, if that's okay.
Yeah, that's fine.
Okay, so I'm going to mute my microphone and turn off my camera, and then Graeme can start. And at the end of his talk, we'll facilitate a Q&A. Okay, thank you very much for attending.
Thanks so much, Samaya. Can I just confirm that you're hearing me?
I can hear you.
Okay.
So I'm sure everybody can. Perfect.
Okay. So, and the slides are showing, huh?
I can see the slides.
Yeah, great. Thanks very much, Samaya, for the opportunity to talk this morning around cryptococcal meningitis. Samaya had originally asked me to talk on the ambition trial that we contributed to investigators at UCT, and I suggested that I make this talk a little bit broader and speak about cryptococcal meningitis in general, but there will be a focus on the findings of the ambition trial. And I'm also aware that I'm speaking to both clinicians and non-clinicians, so we'll try to introduce some of the clinical concepts as we go along. So to start off with, I just wanted to say congratulations to all colleagues at Wits University on your recent centenary celebrations. And then an outline of the presentation. I plan to just give a brief overview of cryptococcosis, then discuss some aspects of epidemiology globally and in South Africa, and then really focus on recent treatment trials that have led to updates in the WHO guidelines. Firstly, the ACTA trial, and then the AMBITION trial, and deal with the issue of management of raised intracranial pressure in patients with cryptococcal meningitis, and end off with just a few slides on prevention issues. So cryptococcal meningitis is a little bit of a misnomer because it's actually a meningoencephalitis. We see the organism both in the meninges lining the brain, as well as in the brain parenchyma itself. And the manifestations are of both a meningitis and an encephalitis in some cases. And it's a subacute onset. Usually patients have had symptoms for 1 to 2 weeks or even longer when they present. And as you'll see through the talk, even with treatment, it carries a high mortality. It's in our context in South Africa, mainly seen in people with HIV infection and a CD4 count of less than 200 who are either not on antiretroviral therapy or failing the antiretroviral therapy with a low CD4 count. We do see it in other immunosuppressed conditions, but far more commonly in HIV positive patients. And the diagnosis is a relatively easy and reliable diagnosis to make. So with a lumbar puncture and on the cerebrospinal fluid, you can detect the antigen of the organism or culture the organism from the CSF. So Cryptococcus is a yeast, and it's found quite ubiquitously in the environment as a saprophyte. It lives on dead or decaying organic matter. The form of Cryptococcus that we see causing disease in South Africa, Cryptococcus neoformans, is found in high concentrations in bird excreta, but also found in the soil quite widely. And it is obviously recognized as a human pathogen, but mainly as an opportunistic pathogen causing disease in people with suppressed immune systems. Cryptococcus, visualized under an Indian ink stain, with an Indian ink stain under the microscope, as a very thick capsule composed of these complex sugar molecules, GXM and GalXM, and a smaller amount of manoprotein in the capsule. And this capsule plays a key role in the pathogenesis of the condition, in that it allows the organism to protect itself from the immune response to a degree. We divide Cryptococcus up into 4 serotypes, and the Cryptococcus neoformans is divided into two varieties in serotype A and D. And the majority of disease that we see in South Africa is related to Cryptococcus neoformans rather than Gatii. So just one slide on cryptococcal infection and the immune response. There are a lot of parallels with TB and the disease progression and pathogenesis that we see with TB, but importantly, there's no human-to-human spread. People become infected by inhaling the spores of Cryptococcus or the desiccated yeasts that are in the environment and have been aerosolized. Those with a thin capsule reach the terminal bronchioles and the alveoli, the distal parts of the lung, and interact with the immune system. And in somebody with a well-functioning immune system, cells like macrophages will ingest the organism and kill it. And so that the outcomes are, potentially elimination or development of latency of the infection, but probably elimination is the outcome in most people. Or in somebody with a compromised immune system, you can get contained disease, pulmonary disease, or it can disseminate. And obviously, when it disseminates to the central nervous system, that's when we see the meningoencephalitis. And this slide really illustrates well what the progression or the infection and then progression of disease through to meningitis. So, as I've said, Cryptococcus neoformans found in high concentrations in bird excreta, but also in soil. The spores are breathed into the lungs. And somebody with a competent immune system, that'll be contained and usually eliminated at that stage. With the immune suppression, then the yeast is able to disseminate into the blood, into the central nervous system, and cause the meningoencephalitis. And of course, this period between it getting into the lungs, getting into the blood, and ultimately disseminating into the central nervous system is an opportunity to detect the infection early and potentially prevent progression to meningitis. And that period, when antigen of the organism is detected in the blood before patients develop meningitis symptoms, is on average about 3 weeks, but can be up to 3 months. And that's from a retrospective study that was done in Uganda about 20 years ago. So that I'll come back to that when I discuss prevention, but that period of time when patients have antigen in the blood but don't yet have meningitis is an opportunity for intervention. So in terms of the epidemiology, this was a paper that's just been published in the last few weeks, giving an updated estimate of the global burden of HIV-associated cryptococcal infection. And it's a modeling study where they looked at the epidemiology of HIV, then the proportion of people that had advanced HIV. We know quite reliably what proportion of people with a CD4 count of less than 200 have cryptococcal antigen in their blood, and then what proportion will progress to meningitis. And overall, the estimate is globally 180,000 cases of cryptococcal antigen in the blood. 150,000 will progress to meningitis, and just over 100,000 cryptococcal deaths, and the majority in sub-Saharan Africa. Overall, it's thought that cryptococcal disease accounts for 19% of AIDS-related mortality, and that makes cryptococcal meningitis the second most common cause of death in people living with HIV worldwide after TB. But importantly, this is a statement from the paper and something to reflect on. I think really important for epidemiologists is that death from cryptococcal infection remains a marker for failure of the HIV care cascade. And what that means is that if we were to achieve 100% coverage of antiretroviral therapy early in the course of disease and maintain patients' CD4 count of well above 200, we would hardly see any HIV-associated cryptococcal disease. We see cryptococcal disease because patients get diagnosed with HIV late. They start antiretroviral therapy late. They disengage from care in a proportion of patients, and they have virological failure on treatment. And so, if we were to improve the HIV care cascade, we could go a long way to reducing deaths from cryptococcal meningitis. And this is just showing the annual incidence of cryptococcal infection by absolute numbers. And quite clearly, South Africa has the highest numbers of people developing cryptococcal infection each year. And this is data from Nilesh Govender at the NICD. Nilesh shared the slide with me, showing that over the 15 years from 2005, what you can see is the lab reported cases of cryptococcal infection. And in gray is the cases of cryptococcal meningitis. You can see relatively stable over the time period, perhaps a slight decrease, which would be due to better ART coverage in recent years. But what you're seeing is the yellow only emerges in 2013 and then increases. And that's due to the cryptococcal antigen screening program that was obviously now detecting cryptococcal antigenemia. And those patients, as I'll come back to, are put on preventive fluconazole. Preemptive fluconazole, and that could be also contributing to preventing some of the cases of meningitis. But I think one of the messages from this slide is that cryptococcal meningitis remains a very common cause of morbidity and mortality among people living with HIV in South Africa. And this just reflects the fact that over this time period, when patients are diagnosed with meningitis in our hospitals, mortality remains substantial, as about 1 in 3 patients die while in hospital, and that has not changed in the clinical services over this time period. So to move on to treatment of the condition, broadly speaking, there are 3 treatments: amphotericin B, which has antifungal activity by forming channels or puncturing holes in the membrane of the yeast. Fluconazole, which inhibits membrane synthesis, and then flucytosine, which interferes with nucleic acid synthesis, but which is never used on its own because it's very prone to developing resistance. And then just to say on this point that we have 2 forms of amphotericin, amphotericin B deoxycholate, and then liposomal amphotericin B. And liposomal amphotericin B has a better safety profile. It's essentially the same drug, amphotericin B, but packaged in these microscopic lipid particles. And our paradigm for treating cryptococcal meningitis has been the same for several decades now. It involves 3 phases. The induction phase, usually while patients are in hospital and they're sick with the meningitis. And that's high doses, often multiple therapies for the first 2 weeks, followed by a continuation phase, usually when patients have been discharged from hospital for 8 weeks, of higher doses of fluconazole, and then stepping down after that to the maintenance phase or secondary prophylaxis to prevent recurrence. And that's continued, and obviously patients start antiretroviral therapy, and the fluconazole is continued for at least a year to prevent recurrence. And when patients have experienced immune recovery, the fluconazole can be stopped. So I'm going to be telling you about 2 trials that have really led to fundamental changes in the treatment of this condition that have been published over the last 6 years. The first is the ACTA trial, and this was conducted in several African countries, led by Tom Harrison and his group, together with collaborators across those sub-Saharan African countries. So before the ACTA trial, the induction therapy for cryptococcal meningitis, so for the first 2 weeks, was 2 weeks of amphotericin B plus flucytosine in high-income countries. In South Africa, we did not have flucytosine registered, and we had no access to flucytosine. And therefore, the regimen that was being used at the time of, prior to the ACTA trial, was 2 weeks of amphotericin B plus fluconazole. And in many African countries, not even amphotericin B was available. So patients were treated with fluconazole monotherapy. Amphotericin B was not available because of its cost, but also the difficulties with administering it in settings where there wasn't ready access to intravenous lines or ability to monitor the therapy for its toxicities. And so that fluconazole monotherapy, is really a substandard therapy, and in clinical settings, over 50% mortality with patients treated with fluconazole monotherapy. And so what the investigators in the ACTA trial were looking to find was more readily implementable regimens for treating cryptococcal meningitis in countries across sub-Saharan Africa, realizing that there was limitations in access, there were cost issues, and that 2 weeks of therapy was sometimes not feasible in many settings, and also to reduce side effects. So what was done was to compare essentially 5 different regimens. I'll just go through them one by one. That regimen 1 was a regimen without amphotericin B, all oral regimen of fluconazole plus flucytosine. Regimen 2A and 2B were 1 week regimens with amphotericin B with either fluconazole or flucytosine. And regimen 3A and B were 2 week regimens with amphotericin B plus fluconazole or flucytosine. And they pre-specified in their analysis that they would do a comparison of the oral versus the 2 week regimens. So that was 1 versus 3A and B. The 1 week versus the 2 week regimens. So 2A and 2B versus 3A and 3B. And then the fluconazole versus flucytosine as an adjunct, be it 1 or 2 weeks. And then a comparison among each of the 5 regimens. And as you can see, this was done in Cameroon, Tanzania, Malawi, and Zambia. And I'm not going to show you all of the results. I've chosen 2 of the key results to show you. The first is the analysis where they compared adding either fluconazole or flucytosine to amphotericin B. This was regardless of whether it was 1 or 2 weeks, combined pooled those 1 and 2 week regimens. And what you can clearly see is at the primary endpoint analysis of 10 weeks, mortality was substantially higher in the fluconazole arm versus the flucytosine arm. And the hazard ratio for mortality was 1.6 for, essentially 60% higher for fluconazole rather than flucytosine. Up until this point, there had been preliminary evidence to suggest flucytosine was a better drug than fluconazole as an adjunct to amphotericin B. But this was the first definitive evidence from a large trial to show very clear benefit in terms of saving lives from flucytosine compared to fluconazole. So essentially, looking at the other way around, about a 30% reduction in deaths if you use flucytosine rather than fluconazole. And the other analysis that I want to show you from ACTA was, some actually quite surprising findings when they compared all 5 arms against each other. And what you're seeing at the bottom is the probability of death by 10 weeks for each of the 5 arms. And what immediately jumps out is the lowest mortality was the 1 week of amphotericin B plus flucytosine at 24%. And that was lower than, and significantly lower than the 2 week regimens. And this was a slightly paradoxical finding because you would expect that a longer treatment for such a life-threatening condition would lead to lower mortality, but actually a shorter treatment here was resulting in significantly lower mortality than the 2 weeks of treatment. And the investigators' conclusion from this was that the 1 week optimally balances the benefits of the antifungal effect against the toxicities. And you're getting the best balance of those at 1 week, and perhaps extending to 2 weeks, you start to get some mortality from the toxicity associated with amphotericin B. Interestingly, the second best performing regimen was the oral regimen without the amphotericin B, so fluconazole plus flucytosine, and there the mortality was 35% at 10 weeks. So this, the publication of these findings led to an update of the WHO guidelines in 2018, and there the preferred induction regimen that was advised in this guideline update was this 1-week regimen of amphotericin B plus flucytosine, and then obviously followed by the maintenance fluconazole. And alternative regimens were given, recognizing that in many settings, those drugs are not widely available. And I'm going to come back at the end of the talk to the issue of drug access and the limitation in access to flucytosine in particular. Just to say that the findings of the ACTA trial have been replicated in an observational study that was published by Rudzani Mishal and Nilesh Govender from the NICD. And this was looking at data in the clinical services from 19 sentinel hospitals in South Africa. And what the investigators did was look at mortality among patients treated with a flucytosine regimen compared to patients treated with other regimens in the same hospital, and then adjusted for relevant confounders that are known to impact on outcomes. And after adjustment, being treated with flucytosine regimens was associated with a 53% reduction in mortality. Obviously, there's potential for residual confounding. Some patients might have not been treated with flucytosine because their prognosis was assessed to be too poor, and you can't essentially capture that in this type of analysis. But nonetheless, this does show that in a clinical service setting, the findings of the randomized controlled trial were reproduced. So then to move on to the AMBITION trial. So this trial really was a further development on the foundation laid by the ACTA trial, and was looking to extend some of those findings in evaluating another novel regimen. And just to give you, this was the publication from earlier this year in the New England Journal of Medicine. And just to give you some background to the AMBITION trial. I've already made the first point, and then the second point I've alluded to is that conventional treatment with amphotericin B deoxycholate, so not the liposomal form, the non-liposomal form, is associated with significant drug toxicities. What the ACTA trial that I've just shown you demonstrated was that the shorter regimen of 7 days of amphotericin B given with flucytosine was the optimal treatment of the 5 regimens compared in that study. And the other bit of background is that the liposomal amphotericin B, or ambisome, is less toxic and has a longer half-life and effectively gets into the central nervous system. And in animal studies, it was shown that it can be found in the central nervous system after 1 or 2 doses for up to 1 to 2 weeks. And due to its physiochemical properties, it actually is retained within the central nervous system for 1 to 2 weeks after 1 or 2 doses. So that's an important bit of information, because it suggested that an abbreviated dosing strategy could still lead to prolonged effect from liposomal amphotericin. And importantly, Joe Jarvis and colleagues who led the AMBITION trial had performed a phase 2 study prior to this phase 3 study, showing that a single high dose of liposomal amphotericin B at 10 milligrams per kilogram, which is 2 to 3 times the usual dose of liposomal amphotericin B, the usual daily dose, was non-inferior to 14 days at clearing cryptococcus from the cerebrospinal fluid, and was well tolerated. So the phase 2 study did not look at clinical outcomes. It looked at clearance of the organism from the cerebrospinal fluid, which is a reasonable surrogate for clinical efficacy, and showed that this single dose was effectively clearing the cryptococcus from the CSF. And that was the basis for taking this forward to the phase 3 trial. So this is the graphic from the New England Journal of Medicine, showing the regimens that were compared in the AMBITION trial. Essentially, this was a trial comparing just 2 regimens. At the bottom in blue is the control regimen, which was now the WHO standard of care based on the ACTA trial of 1 week of amphotericin B deoxycholate plus flucytosine, followed by 1 week of fluconazole at a high dose. And the experimental regimen was here a single IV infusion of high-dose liposomal amphotericin, followed by 2 weeks of oral flucytosine and oral fluconazole. And if you think back to what I showed you for the ACTA trial, essentially what was being compared in this study is, in blue is the best performing regimen in the ACTA trial, and in yellow is the second best performing regimen in the ACTA trial, but with the addition of the single high dose of liposomal amphotericin B. And the hypothesis was that by adding the single high dose of liposomal amphotericin B to the second best performing regimen, it would provide a non-inferior regimen to the standard of care, but that was also better tolerated. And so this is just showing you the schema. Patients were obviously screened on admission to hospital. Those that consented were randomized to either ambisome arm, which I've shown you is a single high-dose liposomal amphotericin B with then the 2 oral drugs taken for 2 weeks, or the control arm, and then it got maintenance fluconazole and initiation of antiretroviral therapy after 4 to 6 weeks. And then the primary outcome was assessed at 10 weeks. And the primary outcome was all-cause mortality at 10 weeks, a number of secondary outcomes summarized in the slide. The trial was conducted across multiple sites in Africa, 5 countries, Uganda, Malawi, Zimbabwe, Botswana, and South Africa. And we were involved in leading 2 sites in Cape Town at Mitchell's Plain Hospital and Khayelitsha Hospital. Inclusion criteria were adult patients with the first episode of cryptococcal meningitis being HIV positive. Patients were excluded for the reasons shown, and there were late exclusion criteria based on the lab results if those came back with low platelets, neutrophils, or a high ALT. So these are the baseline characteristics. I just want to sort of highlight a few issues that Glasgow Coma Scale of less than 15, so patients with impaired level of consciousness, was about 1/3 of patients, similar in both arms. And the median CD4 count right at the bottom there was around 26 to 28. And so, you know, the patients in this trial had advanced immunosuppression. And then to move on to the headline findings of the trial, which, as I said, was the primary outcome was all-cause mortality at 10 weeks. This was a non-inferior design. So the analysis was performed to evaluate whether the ambisome arm was non-inferior to the control, and the non-inferiority margin that was pre-specified was a margin of 10%. And essentially, you can declare non-inferiority if the upper bound of the 95% confidence interval, and it is well, in this case, it was a 90% confidence interval, is below 10. And what we observed was in the intention to treat analysis that mortality was 24.8% in the ambisome arm at 10 weeks, and then the control arm was slightly higher at 28.7%. The difference was around 4% in favor of the ambisome arm, and the upper bound of the 90% confidence interval was 1.2%. So well below the pre-specified 10%. Similar findings in the per protocol analysis. And just demonstrating this, graphically, what you're seeing, and I'll just focus on the intention to treat population, is this is the difference between the arms, about a 4% difference between the arms, favoring the intervention arm, and what you're seeing is that that was well below the 10% pre-specified non-inferiority margin. So based on the findings, we could declare that ambisome arm was non-inferior to the control arm, and in the adjusted analysis, there was even a suggestion of superiority in that the 90% confidence interval did not overlap 0. And this is just showing on the Kaplan-Meier curves that the mortality was slightly lower in the liposomal amphotericin B arm than the control. But I think that the main message is that it was non-inferior, because if one looks at other time points, and particularly in the lowest row there, if one looks at 16 weeks, then mortality was 28% in the AmBisome arm and 29% in the control arm. So about 16 weeks, the mortality was very similar in the two arms. So, that suggestion of potential superiority at 10 weeks is not seen at 16 weeks. And therefore, I think the main message is that the intervention was non-inferior. The other hypothesis with respect to the secondary endpoints in this trial was that the intervention arm would be safer and better tolerated and have fewer adverse or side effects. And that was clearly demonstrated. If one looks in the second row there, the grade 3 and 4 adverse events were less common in the AmBisome arm than the control arm. Anemia in the third row, both grade 3 and 4 anemia was significantly less common with the AmBisome arm. And if one looks at blood transfusions, then it was 8% in the AmBisome arm requiring blood transfusions, 18% in the control arm. This is due to the known side effect of anemia from amphotericin B, but less commonly with the liposomal amphotericin B. And then the rise in creatinine was less in the intervention arm. And importantly, another side effect of amphotericin B is that it causes irritation and inflammation in the veins in which it's infused, gives rise to thrombophlebitis, and that can become secondarily infected. And thrombophlebitis requiring antibiotics was less common in the intervention arm at 2% compared to 7% in the control arm. So across a number of side effects, this was less with the single dose liposomal amphotericin B than with the 7-day regimen. So the conclusion was that a single high dose of AmBisome given with flucytosine and fluconazole was non-inferior to the current WHO recommended standard of care for HIV-associated cryptococcal meningitis. The AmBisome regimen was associated with significant reduction in adverse events, including less anemia, fewer transfusions, and a smaller increase in creatinine, and as I said, less thrombophlebitis. And this offers a practical, easier to administer, and better tolerated treatment regimen for cryptococcal meningitis in Africa. But there's an urgent need to broaden access to AmBisome and flucytosine. So the findings of the AMBITION trial have rapidly been translated into international policy. There's been an update this year of the WHO guidelines for the treatment of cryptococcal disease. And the take-home message is that the AMBITION trial regimen is now advised as the preferred regimen for induction therapy of cryptococcal meningitis globally. Obviously, because of limitations in access to both liposomal amphotericin B and flucytosine that I'm going to come to, there are alternative regimens advised, but really aspirationally, it's now advised that countries try to move towards this regimen because it's non-inferior to what was the standard of care, but also safer for patients. So what are the barriers to implementation of these regimens that I've spoken about, the ACTA trial regimen and the AMBITION trial regimen? Firstly, this is a slide from a publication in 2016 showing that flucytosine is largely unavailable where it's needed most for the treatment of cryptococcal meningitis. And you can see at that point, it wasn't registered in a single country in sub-Saharan Africa, and that's largely the situation today. But in South Africa, the myelin flucytosine product has been registered. It was registered in December last year, and that provides an opportunity for us to introduce it for the treatment of our patients. And as I clearly showed you from the ACTA trial, it has a benefit in terms of reducing deaths from cryptococcal meningitis. There are still major problems with access to flucytosine. There's only one supplier, and that's Mylan in South Africa. In South Africa currently, there are other products internationally. There's only one that's registered, the Mylan product. It has still only been available in certain hospitals across South Africa, and has not been available in all our hospitals. Just last week, it was included in an essential medicine list, which now gives the opportunity for it to be put on the tender and incorporated in the standard regimen for across all public sector hospitals in South Africa, but that will take time. And the other problem is global supply issues. The Mylan product, there's been a supply problem from May this year due to the limited access to the active pharmaceutical ingredients. So even in those hospitals that did have access to flucytosine, they've had to go back to fluconazole regimens. But we're hoping that with another product coming in through Section 21, as well as Mylan addressing the problems of supply, we will soon have access to flucytosine across all hospitals in South Africa. The other major issue in terms of access is the cost of liposomal amphotericin B. Gilead have announced that they will make an access price for the drug at $16 per vial, but that's not currently available in South Africa. It's only available in a limited number of countries across Africa. And at this cost, a cost effectiveness analysis done on the Ambition data suggests that it would be cost effective to implement in the public sector in South Africa. But the problem currently is that Gilead do not distribute the liposomal amphotericin B in South Africa. They've got an agreement with key oncologics that do distribute the drug, and the cost is over 10 times higher at $195 a vial. So if one takes those costs and looks what it would, the cost is to treat a patient with liposomal amphotericin B based on the doses used in the Ambition trial, you need to use 12 vials for a 60 kilogram patient. And at the Gilead access price, that's just under 3,000 Rand. But the key oncologics price, it's 34,000 Rand, which really makes it completely outside the realms of considering the public sector currently. So we really need to ensure that we get access to the Gilead access price to move this regimen into our public sector programs. And just out of interest, if people are interested in reading further on these issues around access to both flucytosine and liposomal amphotericin B, these were two excellent articles published in Spotlight by Catherine Tomlinson, going into the issues and some of the background issues around the price and regulatory issues. I just wanted to briefly mention one of the complications of cryptococcal meningitis is raised intracranial pressure. It's present in about 3/4 of patients and has been in some studies associated with poorer survival. And it's thought to be due to the yeast organism obstructing CSF outflow and reabsorption back into the bloodstream, and there's a buildup of CSF and an elevation of intracranial pressure. The treatment of that is serial lumbar punctures and removing up to 30 mils of cerebrospinal fluid at the lumbar punctures done daily, sometimes twice a day. And in this study that pooled data from South Africa and Uganda, it was an observational study, so open to biases and confounding. But what was demonstrated in the analysis was, after adjustment for relevant prognostic factors, that doing therapeutic lumbar punctures reduced mortality by 70%. And the South African HIV Clinician Society guidelines suggest that any patient who is admitted with cryptococcal meningitis should have their opening pressure measured on admission to hospital, and if it's elevated, have CSF drained, and if they have symptoms of raised intracranial pressure while in hospital, have a repeat lumbar puncture to drain CSF. In terms of prevention, key prevention is antiretroviral therapy. I mentioned this earlier in the talk, that could prevent the majority of cases of cryptococcal meningitis. Another strategy that has been shown to benefit to prevent cryptococcal meningitis in clinical trials is a fluconazole primary prophylaxis, but that hardly any countries give fluconazole primary prophylaxis. The strategy that is used in some countries, and particularly in South Africa, is cryptococcal antigen screening in the blood. And screening patients in South Africa, the national guidelines are to screen patients with a CD4 count of less than 100. And if they have antigen detected in the blood, then to treat with preemptive fluconazole to prevent progression to meningitis. And this is just the algorithm from the Clinician Society guidelines, going through the various steps in terms of screening patients with a low CD4 count, screening them for symptoms of meningitis, if possible doing a lumbar puncture, even if they're asymptomatic, to exclude meningitis. If meningitis is excluded and the patients are antigen positive in the blood, then preemptive fluconazole to prevent progression to meningitis. And one of the problems is that there's still substantial mortality, even if patients are treated with preemptive fluconazole. And the question arises whether that's adequate treatment, and this is being addressed in the EFFECT trial that's being conducted in South Africa and Tanzania. And Nilesh Govender is leading the trial in South Africa. And this is randomizing patients who consent and have cryptococcal antigen positive in the blood, but no meningitis, to the standard arm of 2 weeks of fluconazole at high doses, and then obviously continuation fluconazole, or the first 2 weeks of fluconazole plus flucytosine. And the hypothesis is that the intensified treatment would reduce meningitis and deaths in this patient population. So in conclusion, then, what I've demonstrated epidemiologically is that cryptococcal meningitis is the second leading cause of AIDS-related deaths globally and in South Africa, that these deaths are a marker of failures in the HIV care cascade. Flucytosine in induction phase of treatment for cryptococcal meningitis reduced deaths by between 30%, and that was in the ACTA trial, but up to 50% in the programmatic data from South Africa. The ambition regimen, which includes just a single high dose of liposomal amphotericin B with then 2 oral drugs for 2 weeks, was non-inferior to and safer than the standard of care. But cost and supply and regulatory issues for both flucytosine as well as liposomal amphotericin B limit access to these optimal treatments for cryptococcal meningitis. I just wanted to thank all colleagues who collaborated on the ambition trial, and other colleagues who've assisted me with slides for this talk. And so thanks again, Samaya, for the opportunity to speak on cryptococcal meningitis, and happy to take any questions.
Graeme, thank you very much for presenting so clearly, and not easy to present to a mixed audience. And you certainly raised some interesting public health questions as well. Before we open to the floor, I think what has come across quite strongly in the talk is how these particular trials can contribute to clinical care, which, as per your bio that was circulated with the talk advert, has certainly been a big focus of your career and contributions. So before we open to the floor, I'm going to ask, you raised some interesting potential epidemiological or public health questions. One was around reduction of mortality. So potentially, before we call on Nilesh to tell us what data might be available for Wits students, that could be one potential topic. Or also looking at, you also mentioned pre-ART, or early initiation of ART as a way of alleviating cryptococcal meningitis. Since as a School of Public Health, we have a strong interest in social determinants of health and in social epidemiology. So I'm going to ask, to put out to the floor and also to you, do you think these RCTs have controlled for any particular confounders that are actually social determinants? So poverty, asset index, anything along those lines that maybe a student interested in social epidemiology can take on? So maybe if you want to answer that, then I can open it to the floor.
So, I mean, just on the issue of the RCTs, because there's randomization, I think that would balance the social determinants and that wouldn't influence the findings. But I just want to take a bigger picture view on that question of the social determinants, because I think that the outcomes in this condition, or the fact that we see it in the first place, are so tightly related to the social determinants. You can think of it in multiple aspects. if we just say, why are we still seeing cryptococcal meningitis in the thousands in our hospitals in South Africa, when we have access to antiretroviral therapy? And and as alluded to, it's the gaps in the care cascade. And so there's questions about the social determinants, why patients are not getting onto antiretroviral therapy. Importantly, why are they disengaging from care? What are the social and economic factors that are contributing to that? Issues around adherence to antiretroviral therapy that are really important questions, not just from the point of view of cryptococcal meningitis, from HIV and generally for public health researchers and practitioners to address. And then, there's the issue of the performance of the cryptococcal antigen screening program. And, when we get the antigen result, getting patients onto treatment, why are we not getting patients onto treatment in significant numbers to prevent the condition? And then there's the long-term issues about people being treated in hospital with this optimal regimen and being discharged home, and the linkage to care and the support that they have to get to their clinic, to get their antiretroviral therapy, to continue getting their secondary prophylaxis. And particularly when they've had a brain infection and they've got challenging socioeconomic circumstances, and now they've had a brain infection that can impair neurocognitive function, and the support to get to clinics and to take their medication. So I think there's multiple social determinants, for why cryptococcal meningitis is happening, why some of our prevention efforts are failing, and then the long-term support and outcomes of these patients even after optimal treatment.
Great. So I can also see some questions for implementation science students. We have a program in that area as well. So there would also be numerous questions, I think, for students to undertake qualitative research as well. Thanks, Graeme. I'm going to now open to the floor. Perhaps we could you've drawn a big crowd, over 100 people I can see online, and possibly more if people are sitting together. So I'm going to take potentially a round of 3 questions, if that's okay, and then maybe you could answer 3. So first will be Francis Aban, who's one of our epidemiology students. He had his hand up first.
Okay, thank you so much, Graeme, for such a splendid presentation. I work in a reference facility in Ghana, specifically in the northern part, which lies within the meningitis zone. Every year we get hundreds of people dying from meningitis every year, as if it's a constant thing. There's a meningitis season, and around that time, hundreds of people die. And one of our major headaches is meningitis and malaria. Like you are talking about meningitis and HIV here. Our major headache over there is meningitis and malaria. Your study revolves around diagnose and treat. I also want to find out if there are some other things that involves preventive mechanism, like the vaccinations. What progress have been made with respect to that, so at least we can be able to curb it even before people get infected. Because in fact, this is one of the major headaches that we are really battling with over there. As much as we are trying to work around vaccinations, constantly hundreds of people are dying every year.
Yeah. So the issue of the meningitis belt in West Africa is really related to meningococcal meningitis, and obviously there's an effective vaccine for now that, and if it's scaled up, as it is being scaled up, is reducing mortality, but that could even lead to further reductions in mortality. In terms of cryptococcal disease, there's been one group that's looked at developing a vaccine, but it really is a field that hasn't developed and hasn't really had the funding to develop. And one of the reasons is that cryptococcal meningitis, mainly affects people with immunosuppression, and giving them a vaccine, they're not going to have very good vaccine take and immune responses. And it's a very niche area. It's people with immunosuppression. It doesn't have the same reach as sort of giving a vaccine in a meningococcus, meningitis belt, where a drug company could see a lot of interest in developing a vaccine for that. And then finally, one of the issues is that we do have effective prevention. So in the form of antiretroviral therapy. So that leads to a reduction in the impetus to develop another form of protection, which would be a vaccine. If the question is just implementing the prevention measures that we have, which is effective antiretroviral therapy. So for many reasons, the vaccine research with cryptococcal meningitis simply hasn't taken off.
Thank you, Francis, for your question. Thank you, Graeme. Jonathan Levine will be next. He's a biostatistician in our department who has worked on a cryptococcal meningitis trial at the Ugandan MRC. So Jonathan, please go ahead.
Thanks, Sumaya. Thanks, Graeme, for a very interesting talk and quite sobering. I was involved in the CryptoPro trial where David Lalou was the PI, and we presented our results at the Ministry of Health, and we showed overwhelming evidence that fluconazole primary prophylaxis was effective, but it was never adopted because the argument was it only was really effective in people with CD4 counts below 100, and with the rollout of ART, that would no longer be relevant. So it's sobering to hear that, in a sense, there was still a place. But my question is more something that your talk highlighted, is that it's still a huge problem. I'd actually thought that while I was involved in this trial, it was very exciting, but it's historical now. And I've always been a bit skeptical about the role of PEPFAR and the 90-90-90 targets, where people seem to over-optimistically state that they're meeting all the 90-90-90 targets. But your talk would suggest either that they're not, or that those targets are insufficient, if we've still got crypto causing 20% of HIV-related mortality. So would you think that we are not meeting the targets? People are just saying that they are, or getting unrealistic estimates, or do you think that the targets are insufficient?
Yeah, I think firstly to say that, I showed you the 2020 data, and there has been some decrease in the numbers and the deaths globally over the past 10 years. So there has been some progress, but you can see still substantial numbers globally and in South Africa. So your question is, why is that still occurring? I think multiple reasons is that one is the targets, the whole paradigm through which these targets are viewed is a kind of linear one. You diagnose HIV, you start treatment, and you get suppression. Whereas the experience for many patients with HIV is that the interactions with the health services are cyclical, and they start treatment, they're on treatment for a period of time, they disengage from care, their CD4 count drops, they get sick, they come back to care, and there's a cycle of engagement and disengagement. Some people it's just a single disengagement, other people it's multiple. We showed in a study that we did in Khayelitsha that over a 2-year period, 25% of people disengaged for 6 months. So that's not really captured in the conception of the 1995, what's now in the 95-95-95 goals, which was 90-90-90. And I think that's a major contributor. That is disengagement from care and then coming back sick with opportunistic infections, and cryptococcal meningitis one of them. That we know that among patients admitted to a hospital with cryptococcal meningitis now, over 50% of them have had exposure to ARVs, and either having major adherence problems or have disengaged from care. And the numbers perhaps aren't reflecting that. And if one looks at South Africa, we haven't yet reached 90-90-90, and we somewhere around 70% of people suppressed on ART. So it's the people that are cycling in and out of care, and those people that are that aren't yet suppressed on ARVs that are contributing. But the issue really is that the majority of people are doing well on ARVs, but there's a substantial subpopulation of people that are disengaging or not suppressed on ARVs.
Thank you, Jonathan, for the question. Very thought-provoking. Thanks, Graeme, for responding to that. We've got about 4 minutes left. I don't see any hands. I think Nilesh is on the call. So I don't know, Nilesh, if you want to make any contribution. I know you may have some data sets. Certainly, Zodwa, Jonathan, and I will reach out to you early next year to ask for topics for students. And we have had Susan and Cheryl work with one of our graduates on the germ study. So are there any particular questions that you think are very topical in the field that students could undertake, and in terms of what's available?
Thanks, Samaya. Just to mention that, we've been conducting surveillance for cryptococcal meningitis since 2002, so continuously for about 20 years. Graeme's shown some of the data in terms of the incidence, looking at our national data, but at 25 urban hospitals, largely, we also collect clinical data on treatment demographics and outcomes of patients with cryptomeningitis. And so that offers an opportunity to look at factors associated with mortality, etc. There are questions that obviously come up. For instance, you saw we used the germs data to look at the impact of the flu cytosine access program. And so, of course, these are observational data and are subject to all the limitations Graeme mentioned, but I think really interesting and useful information. It allows us to understand what's happening in routine care, certainly, and adds another dimension to what's found from the clinical trials. Thanks.
Thank you very much, Nilesh. We will certainly be reaching out to you too. We have about 2 minutes left. If there are no further questions, please join me in thanking Graeme for making.
Can I just make one last point? I just want to elaborate on the issues of research questions for people in the public health field, and I just really want to motivate people, beyond the focus of cryptococcal meningitis, to really consider exploring the issue of the experience and the challenges for people living with HIV of engaging with the ARV program. And that's, both presenting for care and getting onto ARVs early, but increasing problem of people having disengaging from care and the challenges that they face in their lives related to multiple factors. And I think we now have an ARV program that can provide people with a single well-tolerated tablet once a day that's highly effective and can maintain viral suppression and immune function. And our biggest challenges now is to ensure that people get onto ART early, are able to adhere on the treatment and remain engaged in care. And understanding the reasons why that's not happening and the challenges that people have is a critical public health question, both from a quantitative point of view, but also qualitative research to understand that, and then inform health systems to improve, the interactions that we have with people living with HIV and maintain people in care. Because, from a strictly kind of therapeutics point of view, I think we've got an excellent strategy for treating HIV and reducing morbidity and mortality. The key challenge is in our interactions with people living with HIV and ensuring that the systems work for them. Samaya, you're still on mute here.
Oops, I forgot to unmute myself. An MPH student could certainly take on a qualitative project, and they would be very welcome to do so. So that sounds also like something that could be very, very worthwhile. So we have run out of time. It's been a wonderful talk, Graeme. Thank you so much for making the time also to raise critical research questions. Thank you also to Nilesh for attending. Graeme, you are the second speaker from the UCT Department of Medicine to talk at this series. As you know, your chair, Professor Ntusi, has also spoken at this series and also drew a crowd, and I know that he's in the audience. So we hope to engage with you again with your department, and also to invite speakers in the future, and to encourage some collaboration, because I'm sure there are people in the audience who will reach out to you and Nilesh with particular questions. And if you could start a collaboration with a Wits student, that would be absolutely wonderful. So thank you very much to everyone for attending. Don't forget to put your CPD points, your HPCSA number in the chat now that Graeme has finished speaking. And have a great weekend.
Thanks, Samaya. Thanks, colleague.
Thanks so much. Thanks so much.
Thank you.